I think somebody was out this week, right? Morgan, maybe. I know we had one board member out. So anyway, we have a quorum, so we can move forward. I guess I'd like to ask the board members to introduce themselves first. This is Greg Thomas, board president.
This is Landry Fagan, board member.
And hi, this is Lindy Hinman, board member.
And I don't see any other board members on. So we'll just go ahead and proceed. Let me formally kick off the meeting. So we do have a quorum present with at least 3 Board of Health members. So this regular meeting of the Boulder County Board of Health is called to the order at discretion of Executive Director Camille Rodriguez. Notice of this meeting was posted on the website as required by law, included the various teleconference numbers so that people can call into the meeting. Obviously, we still have the COVID-19 pandemic ongoing and the need to do these meetings telephonically. Camille, do you want to introduce the staff who will be present tonight?
Thank you, President Thomas. The staff presenting this evening include Chris Campbell, Deputy Director Lexi Nolan, Deputy County Attorney Trina Ruland, and Environmental Health Division Director Joe Malinowski. There are several other Boulder County Public Health employees present. I won't read all the names at this time, but they are present, and we may call upon them if expertise is needed. And I thank them for joining this evening. And I thank the Board of Health for being here as well, obviously. Good to see you. Thank you.
Just a note, Michelle Haas will also be presenting with us.
Thank you. Dr. Haas, my apologies. You are on my list, but I failed to mention, yes, that Dr. Haas will be presenting too. Thank you.
And Morgan McMillan has joined, board vice president. All right, item 1 on the agenda is public comments. Assume we have some public comments.
Yes, President Thomas, we have 3 members of the public that may wish to speak. The first is Ryan Snow. Ryan Snow. Okay, great. We can move on. Sam Johnson.
Hello, can you hear me?
We can. Yep, in your 3 minutes will start now.
Let me get my camera on here too. So I appreciate that the COVID decisions and mandates have been difficult to make, and I think overall Boulder Health has done a decent job, given the attitudes of the state as a whole and the federal and state governments offering very little support this time. However, I'm ready to express my concern and disappointment over the recent guidance my school has now been given that quarantines are no longer required at all, regardless of vaccination status. And a positive case can come back to school after just 5 days, as long as they are feeling better, even without testing negative. Omicron appears to be at least as severe as wild type, and more data is coming out about the long-term impacts of COVID. Just this week, the CDC released a study showing the risk of diabetes is 2.5 times greater in children who have caught COVID. It's ridiculous that we've seen the messaging and goalposts move month by month from kids don't carry or transmit the virus to kids don't get sick to kids don't die to now kids don't die if they aren't fat and unhealthy. And we continue to ignore that this is a vascular disease which can cause autoimmune and clotting issues in many people, including children, for still unknown time, even after mild infections. I understand people want schools open, but it was misguided to bend the rules so much that we are nearly guaranteeing that every child in those schools will catch COVID in the next few months. In the face of a surge of an unknown variant, we should strengthen our protocols or at least maintain them. If that happens to require schools go remote for a few weeks until the surge passes, that should be the price we pay for continuing to ignore waves until they are full-blown crises. Thank you.
Thank you. Joe Messling?
Thank you, Kate. Can you all hear me?
We can. Your 3 minutes will start now.
All right, thank you very much. My topic's about communication and very respectively to the board. I really have a problem with your accountability to the constituents. I appreciate your service. You volunteered for this role, and it's a hard job. However, I have spoke 5 times in the last 6 meetings, and nobody contacts me. And I get it. It's very uncomfortable to talk to people that have issues, that have disagreements, but I'm going to put some context in this. I lead a school of 500 families, almost 100 employees, almost 900 students. They all have my personal cell phone number. I put it on Facebook all the time. And I really believe that when you're making decisions, you need to engage with the community and you need to engage with your constituents. I appreciate Taylor and Soda and the interactions we've had, but you're the deciders. You're the decision makers. You need to step outside of your box and talk to people that have disagreements with decisions that you are making. I'll just add, again, you need an educator on your task force, a lifelong educator that understands the decisions and things that you are deciding have gigantic impacts on our kids and on our community and far-reaching, more than I believe you're thinking about. So that's my humble request. And I know it's uncomfortable. Sometimes we have board meetings. Well, we have them every month and people come and complain. And you know what? We call them the next day. We call them the next day. We interact with them. Some of my most irritated parents are now board members at the school because I bring them into the process instead of excluding them from the process. I really look forward to hearing from someone about decisions you have made now for going on 2 years. And you need to engage, talk, discuss, disagree, but at least we're not at loggerheads and we can say, we've had a discussion. I didn't change your mind. Maybe I changed your mind, but that's your role. And again, I know there's a lot of guests. My heart, our community, Twin Peaks Classical Academy's community's heart goes out to the Marshall Fire victims. What a tough time. I know you've got other things. So thank you very much for your time.
Thank you. And that concludes the public comment portion.
Okay.
Kate,
thank you.
I believe Ryan is on the line now and ready to make his public comment.
Oh, great. Sorry about that. Ryan Snow. Perfect. We can't hear you actually.
Well, seems like we have some audio issues.
Yeah. Mr. Snow, if you could just maybe ping us in the chat after you've tried, working on the technical difficulties. If the board's amenable, we can just take your comment later in the meeting.
I believe the chat
Yeah,
has
we
been
give that up to
disabled.
that.
Oh, chat's been disabled. Okay, got it. I'll keep an eye out for his hand if he comes
Okay.
back. Thanks.
Yeah, maybe you can call back. Okay, so moving on to item 2, approval of the December 13th, 2021 regular meeting minutes. All we need is motion and a second.
This is Morgan. I move to approve the regular meeting minutes.
This is Landry, a second.
Motion and a second. All in favor? Aye.
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 Thank you. Item 3, don't see Mr. Snow on there. Staffing announcement.
Thank you, President Thomas. I know that I sent the Board of Health an announcement that after an extensive search for one of our director level leadership positions, the director of our strategic initiatives branch, and after conducting interviews internally and externally with those candidates, we did extend an offer and it was accepted by Kelly Hinch. So I just wanted to announce that formally. Ms. Hinch was in the interim strategic initiative branch director role for quite some time, as you have seen in your packet. And she brings over 25 years of global health experience in multiple countries and a breadth of experience in community health planning in general, which will serve us well as we embark on the next phase of a new community health needs assessment and public health improvement plan, among other things. This particular branch of our operations covers so many diverse operational activities, and I'm just pleased that Kelly is bringing all of her experience to this role and wanted to announce it formally to you, even though I've emailed it to you and as well to the public. So I know Kelly is here this evening, President Thomas, and I just would like to see if she wants to say a couple words and then we can move on. Kelly.
Thanks, Camille, and thanks to everyone on the Board of Health and on the call as well. I'm not going to give some sort of Academy Awards type speech or anything like that, of course, but I do want to say thank you to Lexi and Camille for how supportive they've been to me over the last several months, and also to my SIP teams. I know each and every one of them, and I've been in this role except for a couple of months since like November of 2020. And they're a great team to work with. And we have some really important work ahead in 2022, as Camille was mentioning, and we're really looking forward to diving into that. So I'm sure we'll be in touch and talking with you all at some future board meetings as well. And also feel free to reach out at any time. I'm happy to talk with anyone. Thanks.
Congratulations, Kelly. Let's see here. Now we have item 4, Marshall and Middle Fork Fire Situational Awareness.
Thank you, President Thomas, and I know Board of Health, I give you a weekly update on surveillance data, and just this last week I let you know the extent to which Boulder County Public Health has roles and responsibilities relative to response and recovery of the Marshall and Middle Fork fires. And tonight we have Emergency Management Coordinator Chris Campbell here, as well as Environmental Health Division Manager Joe Malinowski, to provide you with an overview of the efforts oriented to the response from both of those vantage points. I believe Mr. Campbell is starting, but I could be mistaken, so I'll turn it over to staff at this point. Thank you.
Sounds good. Thanks so much, Camille, and good evening to the board. Good evening, good evening, community members. And Lexi, I didn't know if you're going to pull up the slide deck. Just a couple slides for you all this evening. The purpose of me joining you this evening is really to provide a high-level briefing on the activities our teams undertook in support of the Marshall Fire, really since that harrowing day last month. Certainly not going to capture all of the many areas we touched in support of the community, and I know a lot of that work was detailed in the director's report. First and foremost, I really want to say our hearts really go out to the community. So many people have been impacted by this tragic event, and I just wanted to really say our hearts go out to the community. At our last Board of Health meeting, I mentioned and talked to the board about our exercise and training plan and really the importance of the emergency management structure to ensure our agency is prepared for complex disasters. And we certainly saw that. What I can say is we really leveraged our incident management team structure, and it's just remarkable. Our staff really stepped up from all parts of the agency and really were incredible in their support of the community. We had over 40 staff supporting this response, and clearly it's been really challenging to take this on considering our COVID response. So just wanted to mention that and really thank each and every one of our staff that has supported this. Just some high-level things to share with the board, and I just want to mention this was simply remarkable. We supported a full evacuation of the Vista Hospital, including patients and staff, and this really met that initial core response function of public health, which is life safety, health, and well-being. We assessed medical needs at emergency shelters and evacuation points. We provided personal protective equipment to impacted community members, and are continuing to provide COVID, flu, and tetanus vaccines at the Disaster Assistance Center. I'd really also like to call out our teams that work with long-term care and assisted living facilities. So we had 9 facilities that were impacted, evacuated during this response. Our teams provided daily check-ins with affected long-term care facilities. They were either displaced or received residents until those residents were able to return. Additionally, the team worked in collaboration with the State Health Department, CDPHE, and created a process for impacted community members to be referred to supportive care in an expedited manner. So just incredible effort by that team. One example of preserving the medical infrastructure, and again, these are core areas that we work on in responses, particularly wildfire responses. Our data team assessed daily bed counts. We were concerned with a hospital unable to be utilized in the county. That's going to impact the ability to provide that high acuity care. So our teams monitored that, worked with all of our partners across the metro region to ensure that we had appropriate supports in place for high acuity care. So simply incredible work there. One last area, and I really want to thank our communications team. Certainly public information in these incidents are crucial, and our teams stepped up and really provided and supported and worked through the entire response structure to provide concise and clear public information, and just really want to thank the teams for that work. Unless there's questions, I'm gonna move this over to Joe Malinowski. Certainly, as we know, on the environmental health side, as we shift our as a community and really look at an unprecedented long-term recovery, those teams on the environmental health side are really taking over the efforts. So, Joe, go ahead. Oh, it looks like there might be questions first, though. I can certainly answer those if that's okay.
Thanks, Chris. I have a quick non-environmental health related question about mental health services and the response, emergency response, and in particular around families with young children that are not in school. Is public health involved in that in terms of our sort of maternal and child wellness programs or other things that might connect families to services?
You know, that might be something I need to get back to you on, Morgan. I know at the Disaster Assistance Center, there's many levels of support, both from victim advocates and mental health partners and other partners. You know, I'd have to verify if those supports are reaching the community members and families you're talking about, but I can certainly get back to you on that and verify.
Thanks, Chris. Yeah, and I'm working a bit as a volunteer on some of the DAC stuff too, so I can, okay. I'm in touch with HHS and community services, but I just didn't know if that part that sort of fits under public health might be in better alignment for public health.
Yeah, I know initially, and I could have gone on for quite a while on this response. There were so many parts, and I just wanted to give a high level overview. Mental Health Partners was a key partner in supporting, certainly as we had evacuation points established and ultimately turned into overnight shelters, providing those behavioral health supports. And I think it was a really collaborative effort to support community members as they were accessing shelters and evacuation points.
I can add a little bit. We're also working closely with early child education centers and the schools very closely to ensure that they have the, and I'm sure Joe will talk about this a little bit more, but that they have the environmental health direction and support to make sure that they have safe environments for children in particular. And our communications department has been working overtime to make sure that we are really messaging to the community what they need to watch out for in terms of safety and where they can find additional supports in those spaces.
And I'm happy to talk about some of the environmental health work that we're doing. I think I have a slide that we could jump to. There we go. Again, I'm Joe Malinowski. I serve as the Environmental Health Division Manager at Boulder County Public Health. Good evening, board. I'm really lucky that I have in all these areas, food safety, water quality, air quality, healthy homes. I'm really lucky. My coordinators have been through several disasters, and I feel like we're very good at our response, especially initially. And really, the event after the emergency operations center pretty much leads the initial operation, and then pretty much at this point after the initial recovery, it goes back to the individual agencies. And for us, it'll be mostly environmental health response here out, but just in the original response and recovery, really focused on food safety. I think there was about 120 restaurants that were impacted. I don't think any were actually burnt or destroyed, but a lot of them were out of electricity and just needed help reopening. So a lot of those will get reopened pretty quickly. We're working with those restaurants, the food safety folks, most to do the initial messaging about what foods to throw out, from smoke damage and just how to really clean up prior to reopening. Again, we're continuing to work with that retail food sector. And water quality, we definitely had the boil water orders and all those. I think it was in 5 different areas, and we worked with the state to make sure that messaging was out, and then eventually to release all the boil water orders as the event unfolded. Right now, there is no boil water orders. There are still some homes that are without water because of busted pipes, but those have been isolated. But overall, the public water systems are considered safe at this time. There's still some questions around people are getting some odd flavors and smells in the water, and we're trying to message some of that and work with the state to see if there's any need to address that further. On air quality, healthy homes, obviously wanted to get a lot of messages initially about the smoke, but then even after the smoke went away initially, it's really around, and it's where we're spending the bulk of our time right now, is really around, is it safe to go into the environment? What's it mean to have this ash that contains a lot of chemicals, a lot of hazardous waste, could be asbestos, could be lead, it's in depositing down this ash, and people just want to know how to clean it up. So we're doing a lot of messaging again, as you heard, just around that ash and how to clean it up. There's still a lot of things we need to do. We have a lot of messaging left over from the wildfires in the mountains, but this fire is a little different because we have homes that are so close to each other. Some homes that are in the vicinity that may be next door to a house that have been burned. So they may not have any burn damage, but they have, obviously interior VOCs and smells and things they're worried about, and a yard that's covered with ash. And how do you go about cleaning some of that? And some of that is the areas that is probably more the difficult part, the people that have not been, again, not burned, but still have impacts we're trying to deal with, so they feel safe to go into their homes. Same with schools, we're getting those questions about is it safe for kids to return to school? And we're trying to work with them as well to let them know what they need to do and understand what they've already done, and perhaps put them in some touch with the people that can, industrial hygienists that can do some testing to help as well. Longer term, I really think that The food safety will be more shorter term, and the water quality issues, I think, just immediate water quality for drinking water will pretty much subside. It's really going to be around this healthy home issue of people continuing to rebuild or move back into the area and just getting messaging out about the hazards of the ash and how to avoid contact and what PPE to wear that's appropriate. Trying to messaging, if you have somebody that's coming in the home, it's going to, offering to clean up your home, trying to get some messaging out to what to look for so that people aren't being perhaps taken advantage of. So again, just a lot of messaging around that part of it. And then the other part is just the long term, where in the county, we have about 150 homes in the county. So they'll be rebuilding there. We'll be doing plan reviews for those for rebuilding and also working overtime, probably in the next 2 or 3 years, getting people rebuilt and rehooked to their on-site wastewater system. So that's another area where we'll be spending significant time in over probably the next couple of years. Happy to take any questions. And I know the next item that you're going to talk about is also, advisory on debris, just to help bring that issue to light and make sure it's cleaned up properly. But happy to take any questions.
Hey, Joe, what do we know about the years of when the various homes that were destroyed were built?
I have not seen any of that data. So are you referring to maybe the impact from lead-based paint and some of those and asbestos?
Yeah, probably asbestos and lead is what I'm thinking.
I know like they did in the Calwood fire that we have, they're pretty much considering all the homes has asbestos, and if it's burnt and destroyed, they're treating it as asbestos and doing that type of cleanup to make sure it's not it's safe.
Okay, thanks.
Yeah, and thanks, Joe. I'll jump in with a quick question about just thinking, and again, we're a ways out probably from the permitting process, but thinking about, what are some ways that we can streamline that now so that when we get there, it can go as quickly and as painlessly for folks who are going through that process.
I think the good thing is that we don't think most of these septic systems are actually damaged. I mean, there may be some components that are damaged. So mostly it's once the house is rebuilt, it's hopefully most of them just need to be reconnected. And we won't charge fees for that. It's mostly just a single inspection usually.
And Joe, this is Lindy. Question for you, similar to what Greg just asked. In terms of the radius of contamination, can you talk to me a little bit about what we think that is in terms of the scope of reach of some of this debris?
I thought I saw something around 2,000 acres was the size. I think it's, to me, the more impact is when you think of 1,000. I think it's 1,084 homes were burnt, totally destroyed, 149 damaged. I think 7 of those are commercial. And then again, in the county, it was more like 150 homes. And about 50 of those are on wells, and those 150 are all on septic. I don't know if that helps some of the magnitude.
Yeah, I think what I'm trying to understand though is with winds and things like that, is there kind of a perimeter around the fire that you would say is potentially not safe and requires mitigation outside of the actual burn site?
I know Bill Hayes is on the line. He's been doing some air quality monitoring. We have several monitors up in the area that'll help tell that. But I think relying on some of these that are outside of the burn area aren't adequate. Bill, do you want to talk about that a little bit?
Yeah, I'll jump in real quick and then head to my next meeting. But yes, if you go to airnow.gov is typically where we send people to find air quality, and you type in your Louisville zip code, it will give you an air quality index, but it's not from a monitor in Louisville. It's likely from a monitor many miles to the north. So our traditional resources for identifying air quality don't have that granular detail to tell us what's going on in these neighborhoods. So we did get last week 3 particulate monitors deployed, one at the Monarch High School and 2 in Superior. And so we're starting to get particulate data right now because of the heavy snow cover. The particulate level is very low. I'm more concerned at this time with VOCs coming off all of the synthetic materials burned in the fire. And we're working closely with CDPHE and NOAA to get some equipment in to monitor for those gaseous pollutants. And so very anxious to be able to share data from that with the public.
Excellent. Thank you so much, Bill.
So Joe, sorry, last question for me. So asbestos is tricky, right? You've got, how does the state health department, have they given any indication how they are going to consider the debris with, let's say, each household? Not knowing, of course, when they were built. Let's say they were built, some of them were built before lead or before asbestos was regulated out of the building materials. I mean, are they going to have to dispose of that as like asbestos containing waste or not?
As I understand, if it's a completely burned home, they're going to require much of that, where they have a roll off in the plastic liner and put it all in there and roll it up like a burrito, and then it has to go to the correct landfills. I know FEMA is pretty much helping with that effort. People can still do it on their own, but then they're required to meet all the permitting requirements of asbestos and having the contractors licensed and all that. If FEMA does it, they take care of all that. So we hope most folks will utilize that service.
That's helpful. Thank you.
Welcome.
Just a last mention that we've been working really closely with the schools, and the good news is that so much of the mitigation steps that they have taken to protect air quality and improve ventilation in the schools in relation to COVID will actually support air quality within the schools themselves.
Lindy, do you have another question?
No, sorry. No, I do not. That
Okay.
was from before.
All right. So then do we want to tackle the next agenda item, which is the debris advisory?
Thank you, President Thomas. This is Camille. And yes, I do have an action item for the Board of Health tonight that fits nicely right after Mr. Campbell and Mr. Malinowski's presentations. And it is a request for the board to approve a public health advisory regarding structural fire debris. Overall, what this document does is it urges local governments, property owners, and other responsible persons to take all the steps necessary to remove debris, but practically so, it urges for those entities to hire professionals to do the work. It takes specialized training and experience, as you were alluding to, President Thomas, to deal with this type of debris. This type of document will not only serve as a communications tool for Boulder County Public Health to use it as a springboard to do education and training to all of the entities listed, but it will also serve us well when and if we apply for any reimbursement from FEMA or any other entities or any grants therein to assist. It's hard to say what it all can be used for, but at this time, it's an excellent document to have on file, especially for FEMA and especially to use as an education tool. And I present it to you for your recommendation, or I recommend for you to consider approving it this evening. Thank you. Looks like we have a couple of questions. Member McMillan, I don't know who went first, so Member McMillan.
Thank you. Just a question about whether or not there's a way to add, or an appropriate place to add sort of an addendum or something that gives people, points them towards resources. So I totally get, it makes a lot of sense to say, please don't do this on your own. But then where can we send people of like approved contractors? And that some of this information is probably available at the Disaster Assistance Center, but just thinking, you know, after that or however long it takes, how can we continue to provide that information so that we point toward people towards resources to make it as as easy as possible.
Yes, that's an excellent point. I think that could change as time goes on. I know that right now at the Disaster Assistance Center, we have several professionally trained entities that actually sift through debris to find heirlooms, but they are not the same types of entities that will actually do debris removal. If I may put one of the deputy county attorneys on the spot, if this was something that you felt was an appropriate addendum, or if it pleases the Board of Health, we could ensure that as part of our recovery response, we could ensure that our communications team provides resources and augments our webpage, whichever it pleases the board to do.
Yeah, I think that makes sense. I mean, it doesn't need to be part of the advisory itself. Just again, in our communications, making sure that we point people towards resources that are available, and as those are added to and updated and all of that, just want to make sure people have the information they need.
Yes, and Member McMillan, I think that the entire Boulder County response team, even including Boulder OEM, has been very aware too in working with law enforcement to understand some of the unfortunate issues of fraud and not so reputable companies that have been coming into the area. And so we will be in lockstep with those types of communications too, so that our public knows the reputable entities with which they can lean on for this type of support. Wasn't there another question, or was that the total? Okay.
Director Rodriguez, I have a question. So just so I understand this, not that I'm implying that we should change it, but why are we using the language encourage rather than require?
The simple answer I have is that if we used the word require, and I see Deputy Attorney Haywood on, I'll have Kate answer. I hope my answer is spot on, but I will lean on Attorney Haywood for the answer. Thank you.
Yes, no problem. I'm sure it's the same answer. There can be a lot of public confusion when we use the word require or order. And I feel like, at this point following, the COVID pandemic, it's best not to use the word require unless it truly is, could be lawfully enforced.
Thank you. I appreciate that.
Okay, so seems like we have basically a 1.5 page public health advisory regarding the fire debris. I assume folks have looked at it because you've already weighed in with certain language questions. So I guess any other questions on this? And if not, somebody who can make a motion to approve.
This is Lindy. I'll make a motion to approve.
And this is Morgan, a second.
Okay. All in favor of Boulder County Board of Health Public Health Advisory regarding structural fire debris? Aye.
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 Okay. And yeah, and just, I can't imagine what the pain of going through this and the need to be patient and to wait and really, it's like there are a lot of things we don't know about our own properties, where we were to go through the same thing. And so it is tricky to put in language that is, require, because the enforcement piece is really hard. I would just say to those people affected and to the folks that they're working with is that, doing this the right way and the safe way, even though it's difficult, can save you a lot of time and hassle, further down the road. So I think it's a really good advisory and good to put that out there. All right.
And sorry, Greg, before you move on, I just want to also sort of echo for anybody from the public who's on here or anyone who's affected that the Disaster Assistance Center really does have a tremendous amount of resources for folks. So to navigate all the various things that they might need or not even know that they need. So encouraging folks to make their way there.
Thanks, Morgan. Okay, so we've got the item 4 and 5 complete. Mr. Snow, can we get an audio check? Any luck? I'm not hearing you. Okay, well, we will move into the COVID-19 data policy and program update. If for some reason he can get back on, we'll take his comment at the end.
Take it away, Dr. Nolan.
Thank you very much. Good evening, everyone. Lexi Nolan, Deputy Director at Boulder County Public Health. And I just want to thank everyone for their patience with public health over the last few weeks. It's been a little bit of a ride, more than usual. We are grappling with a whole lot of different kinds of challenges, even on top of what we have been dealing with over the past year and a half. The Omicron surge is definitely producing some additional strain on our systems as well as our staff. So we really appreciate everybody's patience as we do our best to reflect the best information that we can provide you with, and recognize that this is a really dynamic situation with this particular variant surge. Look forward to hearing your thoughts when we get to the end of the presentation. So let me just work on sharing a little bit. All right, can everyone see that one? Okay, yes. Thank you. So we do have some key messages this evening. First is we want to be really clear that the Omicron surge we're seeing in Boulder County, and I think you folks already know this, but we'll say it for everyone and for the public, it is not unique to our county. This is what is happening globally, nationally, and statewide. The particular patterns are the same. Specific details vary a little bit from geography to geography, and we will try to raise those up as we recognize them. Second, our long-term strategy in our previous agency and community and the community's response has done a fairly good job of preparing the county for the surge. It's not perfect. There are some significant strains in some spaces that we are working to respond to, but I would say that we are certainly in a better position than a lot of our colleagues around the country. The surge breadth and strength does require some further actions to be taken at a time when staff and community energy is pretty depleted and everyone's pretty tired of working in this space. As I mentioned, it's a really dynamic situation. Our data is changing on a daily basis, sometimes in significant ways. We are learning new things about this variant on a daily basis, trying to figure out which report, which study really is the most authoritative. But one further piece of good news is that the 3 key goals that we have been centered on over the past 8-9 months really remain the same and remain centrally relevant: to prevent severe illness and death, to protect our health systems, and to safely return to normal. A little bit of a more micro level, I can say that we're expecting cases to peak in Colorado in late January or early February, and for hospitalizations to follow in early to mid-February. We are seeing increases in hospitalizations among children. There may be a variety of factors. We're not exactly clear on what's happening in that space, why that is happening, but we are continuing to to gather data. We do have new booster guidelines that allow folks ages 12 and up to get boosted 5 months after their full course of vaccines. And we really want to note that Omicron is shaping our thinking and action within the agency and the community. We are putting less of an emphasis on cases and more of a focus on hospitalizations and how do we support health systems. We are also recognizing that the impact of cases particularly is affecting staffing in the community and the ability for our businesses and our community partners to safely stay open. We're seeing that strain in ECE, in K through 12, in jails, law enforcement, hospitality workers, grocery stores, specific other businesses, transportation, and healthcare providers. And so that's not a short list. And that is, you know, a little bit of an off the top of the head list of some of the partners that are really expressing some distress about staffing related to the number of folks who are sick and out. So that is a new strain on our systems. And finally, we're also thinking carefully about the impact of the fire, both the virus on fire affected families and also the broader impact on the fire on virus spread, recognizing that displacement due to the fire may in fact exacerbate or speed transmission of cases and hospitalizations, as well as further impact staffing in the region. And I would like to turn it over to Dr. Haas to talk a little bit about some of the science that is emerging in this space.
All right, can you guys hear me okay? Great. So I'm going to talk a little bit about the emerging science, and I'm going to give my usual disclaimer that the information is evolving and surging exponentially, just like the Omicron surge we're in, and may change in real time. And this happened to me a couple of times last week where I said something in the morning and in the afternoon, the information had been updated. So we will do our best to keep you updated. So this is what I know right now. So there was an MMWR study it was a case control study looking at an outbreak in Nebraska, I believe. And they were able to drill down on exposure time to infection in that cohort. And so it looks like with Omicron, it's about 3 days, which is a shorter time compared to Delta and other variants, which is more on the order of 5 to sometimes 7 days. And then emerging data, mostly from England, has looked at risk of hospitalization, risk of reinfection, protection from vaccines using real-world data that they've posted. It's the Imperial College of London that's doing most of this work. And so from their work, they found that the risk of reinfection might be 5 times as higher with Omicron compared to Delta. So what that means is that if you have had 2 doses of the vaccine, and we'll get into the vaccine efficacy in a minute, or if you were infected with Delta before, your risk of getting Omicron may be 5 times higher, is sort of the way to think about it. So it's pretty high risk of getting Omicron. There have been some
Sorry, Dr. Haas, quick clarification. 5 times higher than your risk was of getting Delta, not compared to somebody who's never had any infection.
Compared to Delta.
Okay, thank you.
And there is some most of the data that I was looking at that I thought was helpful was looking at how to gauge risk of hospitalization, and it does appear that the risk of hospitalization compared to Delta is lower, even to some degree in people who are unvaccinated, but still, I think I want to be clear that when a person is unvaccinated, there's still a high risk of hospitalization. So this is just some shifting here. And so what they found was that it might be from either 0 to 25% lower if no prior immunity, and they looked at prior infection, and then about 50% lower if there was prior infection. So again, this is data from England. So you also have to be careful about applying that to our context because we're not England. So there can be some sort of unmeasured variables there. And then this preprint study, so again, this is not peer reviewed. And so I also want to give that disclaimer as well, this graph that I'm showing you guys, so that this needs to be peer reviewed, so that could change. But what they did, so this is also the same group this is the same UK group that they were looking at, again, people who had Delta compared to people who had Omicron over around, I think it was from November to December. And what they found is that, so they were able to look at the vaccine effectiveness, so looking at breakthrough infections, and in terms of the timing of either getting AstraZeneca, so they were interested in that, and then also the Pfizer vaccine. And so what they found, looking at this graph here, so gray circles are people who had Omicron, and the black squares are people who had Delta. And then looking at how many doses, how many weeks they were out from their second dose over time, and then the impact of boosting. And so what they were able to show is that people who had their 2 doses within 2 to 9 weeks, and then subsequently may have become infected with either Delta or Omicron, the vaccine effectiveness was still very high 2 to 9 weeks after that second dose. And for me as a parent of young kids, this is particularly important, because the 5 to 11-year-olds who just are starting to get vaccinated, will still have a fairly high degree of effectiveness against Omicron, at least 2 to 9 weeks after that second dose. And then according to their, and what they found, it looks as though effectiveness wanes over time and starts to wane as early as 10 weeks after that second dose. As you can see here, you do see some of that impact in people who, it's sort of in the surge of Delta, but less so compared to people who had Omicron. And then the impact of boosting does take vaccine efficacy back up, not quite as high as it was before, but it does raise a higher level of protection with boosting. So again, not peer reviewed, but I think pretty powerful data, and in some ways reassuring, at least for folks who are early to vaccination at this point. But I think it also reinforces the importance of boosters. Next slide, please. Is there one more? I don't know. Oh, okay. Yeah. Actually, there's a question. I can take the question.
Hi, Michelle. This is Lindy. So I assume you haven't shown this data because it's not known yet, but do we know the efficacy and the time period of the booster once you've been boosted?
Against Omicron, at least like sort of real Colorado data.
Yeah.
Ooh, let's see. I don't think I've seen the Colorado data. I'm trying to think. I mean, there was an MMWR. I need to probably fact check myself, but looking at the impact of boosters on mortality. I think that was it. And there's a 90% reduction there. So, but let me circle back to you and just make sure that I'm remembering that paper correctly. But that wasn't Colorado specific.
Okay. So and I think that's fine. I just assume that as the public might be listening to this, for those that have gotten boosted, right, which is sort of the gold standard now, then the question I think is, so what next? And how effective is the booster?
Right. So. But yeah, I will get back to you on that and see if I can.
Thank you. I appreciate that.
And then just in terms of the summary, so, I did appreciate the public comment, and in particular, Mr. Johnson's comments. I usually will tell people the pandemic started for me on March 13th of 2020, which is when they closed the schools. So, I get it. And it's so hard to parent in this pandemic. You want to keep your kids safe. You want to protect their mental health, and you want to make sure they don't get sick. So I totally understand, trying to balance all of those competing priorities. And it is really hard. And I want to say that we have looked at the data, and we can certainly talk offline about this, about, what little there is to try to inform, how we approach isolation and quarantine, how the CDC has landed on shortened isolation and quarantine. And at a high level, what I can say is there was a really large study, of contacts and case investigations. So 730 cases, and I think it was 8,800 contacts. And the long and short of that story is that the vast majority of transmission happens before we know about it, and in the 2 days prior to symptoms, and then on the day of infection, and then it sort of trickles down after that, actually fairly rapidly. And so I do think there is some data to inform isolation and quarantine. I think at this point, it's very, very important to have other layered mitigation strategies, including masking and good airflow, because of what we are now learning about when people are getting infected. And I think that with the humbling, I mean, this pandemic has humbled us in so many ways, but not the least of which is that, we do need extra layers of protection because of when people are becoming infected, is that people are transmitting COVID before they know that they have it, in many situations. So vaccination and boosting, and when we're in this space where there is a lot of transmission in the community, masking and other layered mitigation strategies are really important. We also know, and again, these are very limited data, hard to extrapolate to all settings, that viral clearance is more rapid among people who are vaccinated. So it looks like on balance, probably around 5.5 days versus about 7.5 days. And then also, in terms of how to estimate when a person's infectious, we're using culturing virus from people, but that doesn't necessarily mean when you can culture virus from someone that they're actually able to pass it on to someone else. So there's a lot of sort of nuances to how to interpret some of this. And so I do think that that CDC and in our internal review that we have landed on policies that are pragmatic, that can be implemented, at least at this point, and then we're going to have to lean heavily on other secondary mitigation strategies. With the hand up.
Hi, thank you so much, Dr. Haas, for all of this update and information. It is so hard for me to believe that we are still a couple weeks out from the peak in Colorado, because it feels like everybody has COVID right now. So it's sobering to think that there are going to be more cases increasing. I have a question also about, you were just talking about how quickly, you might get over your transmission phase, right, of when you're most at risk of transmitting the virus. And I'm thinking about just our policy differences between, or recommendation differences between K through 12 and ECE, as a parent who has kids in both of those. And it continues to be, as you just said, a really challenging thing, right, as a parent, to try to figure out, how do I keep my kids safe? And also in the ECE setting, it seems like we still have pretty lengthy quarantine and isolation times. And so I'm trying to understand the thinking difference there as to why we continue to have much longer quarantine and isolation times for ECE rather than what they are for K through 12. And I understand that my under 5-year-old is not eligible for a vaccine, but we also don't have all of our kindergartners vaccinated and so forth. So just wondering a little bit about that.
Yeah, we've talked about that a lot. And, I think where we sort of landed was, kids who are under 5, the whole cohort, there's individuals and then there's the entire cohort. And on balance, there's a higher proportion of kids under 5 who are not, they're not eligible for vaccinated, so they're not vaccinated. And while we're, the 5 to 11s are catching up, more and more of them are becoming vaccinated. And so it was really sort of a, thinking about, all right, there's and CDC hasn't updated their ECE guidelines yet, but what we are talking about and hoping to implement, and someone please correct me, because I know there's some internal talking about this, but we landed on 7 days of isolation, and that's based on, again, very limited. I mean, so the study is an NBA study, so we know that NBA players are not small children. I get it. And it's the best that we have to try to look at when people are infectious. And so in that group of people, people are unvaccinated, they shed virus, and this is looking at cycle thresholds for about 7.5 days. Now, this whole viral, we can go on and on about like viral shedding and culture and all this stuff, but that's really an average. And even the 10 days was an average. Like some people do shed longer. And so I think the other thing to think about is we're trying to be pragmatic about, all right, you know, yeah, it was 7.5 in the NBA study, but people are going to be from like 3 to 8, and you have to kind of pick something that makes the most sense for the whole group. So that's kind of where we landed. And it may be that CDC will come out and still say 10 days for the ECE group. I think that we're still hoping for 7 days. And we're going to give some of the, you know, we definitely want to work with our ECE partners, make sure they're comfortable with it and that they can implement it in a pragmatic way. But that's where we're headed.
I appreciate you talking me through that. Quick also question on the childhood hospitalization rates, Lexi, that you referenced that are increasing. That's the rate of hospitalization is increasing, not just numbers of kids. Is that right? I know it's been happening nationally, and I assume it's been happening in Colorado, that the rate of hospitalization has increased among children.
I believe that's correct. I also see Elena Younger's hand up, who is our ECE subject matter expert that I think is hoping to weigh in on this question from you, Morgan.
Yep.
Hi, Morgan. And thanks, Lexi. I know we do have slides about policy updates, so I'll just keep this really short. But effective January 3rd, so a week ago, we actually did go ahead and shift our ECE quarantine and isolation policies. So they are very much in alignment with K-12's policies, especially when it comes to quarantine, with the only difference being what Dr. Haas just noted, about 2 days longer for isolation for kids under 5 due to the challenges that come with mask wearing. But otherwise, quarantine length and isolation is in alignment with staff between K-12 and ECE, and in alignment for quarantine for children and staff between both groups.
Thank you so much, Elena, for sharing that, because it's been an area that I've been hearing from a lot of folks on and have a personal interest in it. So I appreciate the work that the staff has done in the last month since our last meeting. I know there was talk about just trying to find that balance of helping ECE kids stay in school also as much as we can keep them keep them safe. So thank you.
Ready to move on, Michelle?
Yeah.
Okay, thanks very much. So I'll go through some of the new data that we're seeing in relation to cases, positivity, hospitalizations, et cetera. Someone suggested we should have a trigger warning with this slide, but it is disheartening to see the number of cases and the rapidity with which the cases are accelerating. We're currently at 1,243 cases as our 7-day cumulative case rate per 100,000. If you look across this slide, I know you recognize these red, orange, and yellow lines as really markers of kind of the space that we used to navigate in quite a bit in relation to low transmission, substantial transmission, and high transmission. Back in July, we started to come out of that low transmission into moderate. And that line really represents kind of where our epidemiological team's capacity is to really support the most robust form of case investigation, contact tracing. So we've been out of that space for quite a long time now. This peak back here in November of 2020 was the CU outbreak. This peak in November of 2021 was our Delta crest. And currently we are up here, and we will likely need to revise our scale to accommodate the continued increases that we are likely to see by the time we get to the next Board of Health meeting. So our 7-day positivity rate in Boulder County is about 24.5%. It's only about 5% higher than last week. But there are some data lags, so that may be revised in coming days. Also, just a reminder that the PCR tests that we are doing are becoming increasingly less reliable as around what's actually happening in the community, because at-home tests are being used so frequently and are rarely reported to the state. So there's quite a bit of speculation about what the true community transmission rate is, even up to, it's supposed by some to be up to an order of magnitude higher than what we're seeing reported. This is not our normal age breakout that we show. What we were trying to demonstrate with this graph, this is the percent or the proportion of COVID cases among different age groups. And what we really wanted to highlight for you is that 5 to 11-year-old group, which recently had access to vaccinations, has seen quite a decline in proportion of cases. Additionally, our 65 plus group, which has been the largest uptaker of boosters, is also seeing proportionately low rates, just reinforcing kind of that importance of vaccinations, both in terms of cases and hospitalizations. This is a projection from the Institute for Health Metrics and Evaluation on the daily case projections for Colorado, showing that they are anticipating a peak in early February, as mentioned earlier, and that is similar to what our partners at CDPHE are suggesting. I think what's really interesting about this graph, though, is the projection about the impact of masking on what that peak might look like, and how important that is. And that is one of the kinds of indications of how this community has been prepared for this Omicron surge in terms of really requiring masking and also continuing to reinforce the importance of masking, working to reach out to ensure that the public understands the importance. And even today, we updated our website and released some information regarding the quality of masks being used, and that we're really recommending people use high quality masks and forego the cloth masks in favor of the high quality masks. We think that the masking is one of our most effective mitigation strategies at this point, particularly as Michelle mentioned, some of our other strategies are becoming more challenging and to be effective. And we'll talk a little bit more about that soon. In terms of vaccinations, we are continuing to look very good in terms of, particularly in terms of partial, at least folks who've gotten partially vaccinated, right? So this 5 to 11 group, 58% have received at least one vaccination. And some of the numbers of our teens and our 20 to 29s, which had been quite low a few weeks ago, are moving exactly in the direction that we were hoping. So that is very good news. Our first doses, and we use first doses a lot because it indicates intention to get vaccinated, and it helps us project, kind of where are we having resistance. We are not seeing resistance in 30 and up. We have excellent vaccination rates in those age groups in Boulder County. In terms of our health system data, we are looking at 72% of those who are hospitalized across the state are unvaxxed. It's a little bit lower than it was a few weeks ago. So what that means is we're seeing a slightly higher proportion of vaccinated people being hospitalized, and that may be not because necessarily of the Omicron variant, but just because of some of the way that the numbers work. Hospitalizations in the region did increase by about a third last week. Our PEDS hospitalizations also increased in the region. We're seeing about 62% of hospitals in the region having staffing shortages, and our medical surgical beds and ICU bed Availability is relatively stable, but very low, about 4% and 7%. And I think what's important to understand about why those availability numbers can be relatively stable, even when we're seeing increases in hospitalizations, is that the health system is actively taking steps to defer less emergent care, less urgent care. So they are trying to hold that number of beds open for what we anticipate to be continued increasing hospitalizations. Those three metrics that are in bold are areas where our kind of state set thresholds of what creates an urgent situation have been exceeded. But we also see that PEDS ICUs, ventilators, and PPE metrics have not exceeded those thresholds. We are seeing ER visits and waiting times increasing, and we're seeing significant staff cases, even within hospitals that require staff to be vaccinated, just as we are in the rest of the community. So how is the health system responding? Most of our hospitals have now eliminated cloth masks as acceptable forms of masking among patients, including in outpatient settings. Our combined hospital transfer center plan remains activated to transfer patients so that they can best manage resources. Crisis standards of care for, I'm sorry, there's a duplication there. Crisis standards of care for emergency medical services have been enacted on Friday. That's the first time they've been enacted since April of 2020. It means that only the most severe patients will be taken by ambulance to hospitals. Some patients may be taken to urgent care and other non-hospital facilities. They will be providing guidance on what kind of treatment to provide, PPE, no longer providing certain life-saving treatment. And it may result in not transporting some patients or declining to resuscitate some patients, such as those who are in continuous cardiac arrest and have very little chance of survival. Finally, Avista Hospital, which was evacuated during the fire, is expected to be back online in 2 weeks. So those beds will reopen. The staff has been redeployed to other hospitals to support staffing. So board member, one of the board members asked, maybe several of you asked questions recently about this question about the difference between hospitalizations in Boulder County and hospitalization of Boulder County residents. And so we did some work to look into that question. What is the contribution of Boulder County residents to our system stress? And so we know that Boulder County hospitals admitted at a rate of 37 per 100,000 in the last 7 days. And we have found data that 1.5 per 100,000 was the rate of hospitalization of Boulder County residents. Historically, Boulder County residents have not exceeded 5 per day per 100,000. So that gives you a sense of the proportion of Boulder County residents contributing to the hospitalizations that are overtaxing our system at the moment.
So sorry, Lexi, just to clarify, that data is telling us that our hospitals are being filled by people who are not Boulder County residents?
Largely.
Okay.
Lindy?
Oh, sorry. Lexi, could I have you go a couple slides back to the IHME graph? I think that was the acronym. So I'm not sure I'm interpreting this correctly. So I'm seeing the blue line as third dose. So is this projecting that the way can you help me interpret that what the third dose line really means there? I'm having a hard time understanding that.
So I think that the IHME projection, and I'd have to do a little digging to confirm this. I don't want to speak too much out of turn. But I think that it's projecting kind of the current numbers of folks who are vaccinated and what the addition of boosters might be in this very short time period that we have, right? It's not a long time period. That's the thing about this surge. It's going to move through very quickly. And so it's difficult to see that trying to massively increase vaccinations or boosters right now will affect the peak. It may help with hospitalizations later and help to reduce deaths. But given the short time frame and the fact that it takes a couple of weeks for another shot to really increase protection, it's difficult to see how additional boosters at this point would make a huge difference in the peak. In the peak, yeah.
Got it. Okay, thank you for that.
Yeah, and the other thing is those numbers generally are not going to match what you see reported by CDPHE because, like Lexi said, there are you can't test everybody, right? And then cases like rapid tests go unreported, so they assume a fraction that is higher than what is reported that is just undetected. And so that's why those numbers they look pretty high, and they will likely be higher than anything you'll see from CDPHE, heaven willing.
Thank you. So quick update on deaths. We've recorded 71, although I had to adjust the slide this afternoon to recognize 75 deaths since May of 21 because we had 4 deaths between this morning's report and this afternoon's, which brings us to a total of, I believe, 329. So we are continuing to see deaths. We'll have to watch and see what the impact of the recent hospitalization surge has on deaths over the next couple of weeks. So I mentioned earlier that, we've done some great things to prepare our community, particularly in terms of masking and having really high vaccination rates. There are some additional BCPH responses that we are looking at enacting to try to support our community right now. We've been partnering with the state to set up a mass vaccination site at the fairgrounds that I believe is now operational with appointments required. As mentioned, we've revised school quarantine and isolation guidance to better support maintenance of in-person learning, really trying hard to pay attention to what the science gives us some flexibility in relation to how we can manage protection and balance safety and in-person learning. We have increased, we do a lot of public communications anyway. Lately, we have released communications. We're partnering with our vaccine verification program partners to have them encourage masking during the Omicron surge, even though they aren't required to, just for now. To use quality masks, as we've mentioned, including outdoors, and to discontinue the use of cloth masks to the public and to the public to reduce non-essential social interactions and encourage remote work whenever possible. Our surveillance and epidemiology teams are having a lot of challenges managing the data situation, which includes real data lags simply because of the volume. The system is being taxed in that space because the data is changing so rapidly, and just recognizing that we need a little bit more information and time to understand the real human impact of this surge so that we can prioritize best. We have paused highly work-intensive data collection and verification indicators. These include race and ethnicity data as well as municipal data. It takes a lot of work for our staff to go in and really populate that data, and it's just not something that's feasible right now at this point in the surge. And we are further prioritizing case investigation and contact tracing because this surge is transmitting so quickly that a lot of that work is less effective, and we really need to focus on outbreaks in particular, and that's pretty much all our staff have capacity to do at this point. We did additionally provide support to fire victims at the Disaster Assistance Center. We distributed 8,500 N95 masks, 8,000 pairs of gloves, 5,000 rapid tests, 1,100 COVID vaccines, 220 Tdap, and 500 flu vaccines to try to ensure that particularly vulnerable population right now has what they need to be safe. So I'm going to move to K through 12, but I'll pause to see, are there additional questions or hands up left over, or are there new ones?
Lindy?
Oh, I'm sorry, guys. I'm terrible at Teams. I took it off.
I do have a quick question, Lexi, on I totally appreciate that the staff is overwhelmed and cannot handle collecting as much data around so many cases. Just a thought about whether or not we're able to look at if there's anything that stands out in hospitalized cases around vulnerabilities in our community that we should be looking at. So that's just a thought about how do we shift how we're thinking about equity, or whether or not there's vulnerable populations that we should be focusing our very limited capacity on. So that was it. Thanks.
It's a really interesting question. I'll also say that I know that we've seen some, we're seeing some early attempts to do some projections using limited data sets that could be extrapolated to the broader case affected population. So we may have some workarounds by the time we get back together again. Certainly, as soon as we find some solutions, we will want to reincorporate particularly the equity indicators as well as the municipal indicators. But I will make a note of your question about focusing on hospitalization patients and whether that is a possible temporary response. Thanks. All right, so we'll just take a quick look at K-12 because it's January. Kids are back from holidays. There is some action in this space, and we know board members and the public are interested in getting an update specifically on this group. So this is the 7-day average of cases in Boulder County by age. So, our littlest ones in the brown line, 0 to 4. 5 to 11 is this highest group. 12 to 14 is here, and 15 to 17 is in this peach color. I'll be interested to see if that continues. I suspect it won't, but this gives you a little bit of a sense of how the distribution, or that not the distribution, but the number of cases in each of those age groups is falling out. And I think one thing that's interesting is how the 5 to 11s have really kind of been charting their own course in a separate collection than some of the rest. And yet, when we get to Omicron, we see surges across the board. Just a repeat of the previous slide in relation to vaccinations as a reminder that we're actually doing pretty well, at least in terms of first doses. This probably would have been the space for me to show second doses too, which would have been helpful. But we do know that a lot of the vast majority of these first doses also include second doses, with the exception of this 5 to 11 group, many of whom are still having to wait their 4 weeks to get their second dose. So we are doing quite a bit of action to support the schools, working very closely with our school health staff. We continue to provide vaccination clinics with both districts. Our teachers are largely vaccinated. That's good news. We put a particular emphasis on that last year. Other staff, however, are less vaccinated. Our bus drivers, our cafeteria staff, our janitorial staff, our mechanic staff, and in many school districts across the country, it's those staff that are getting sick the most, and unfortunately creating the cause of a lot of disruption in being able to maintain in-person learning. In Boulder County, we had a delayed start in one of the school districts last week, that first week of school, because we had so many bus drivers who were out, is my understanding. But there are many things that the schools are working really hard on to support in-person learning, including high quality ventilation, including HVAC systems in so many of the schools, daily cleaning, distancing 3 feet when possible, student symptom screening by parents, and these are all mitigation efforts that are still currently happening. Community and mobile testing sites, school masking in all metro areas except Douglas County, and continued communications and letters to parents to keep them updated on what's happening and how they can support keeping in-person learning. So in terms of the school impacts, historically, we've seen relatively low classroom transmission. During the January return last week, we did see significant students and staff missed their return because they were isolating from exposures over the holidays. We know several staff and students have been hospitalized, including 4 with severe illness and 1 death. I was notified not in time to change the slide. It's actually 5 with severe illness. School health staff are feeling very overwhelmed, and we are working as hard as we can to support them. Part of the reason that we were able to work really cooperatively on the isolation and quarantine guidance changes was that those changes also did align with supporting school staff. Some private schools have delayed returning to in-person. Denver moved and are using testing to return. Denver moved to remote learning 1 day last week due to support staff shortages. And the fire impacts are creating additional stressors particularly for BVSD staff who have children who were affected by the fires and have additional needs. So just a note there. And I will turn it over to Trina Ruland to talk a little bit about some of the guidance changes that we've seen lately.
Thanks, Lexi. Elena had brought up some of this earlier, so I'll go through it fairly quickly, but BCPH has recently made changes to our early childhood education and childcare guidances, most importantly and significantly in the quarantine and isolation realms. We have followed CDC guidance. We are moving quarantines down to 5 days with the caveat that children may quarantine for only 5 days if they can mask upon return. So that means that if a child has a medical exemption, which is permitted by the order, they would have to actually quarantine for the full 10 days because they could not mask upon return. And the under 2 crowd does have to quarantine for the full 10 days because the under 2 crowd doesn't mask. We've also removed the whole classroom quarantine requirements, but we of course are allowing child cares and daycare centers to follow more strict guidelines if they want to. However, with the important caveat that if an unvaccinated student has an exposure to a positive COVID-19 case at home, they must quarantine. They should not come into school. In the isolation realm, so these are students and staff who have positive COVID-19 cases, staff can now return with a mask after 5 days of isolation. For children, as was mentioned earlier, this has changed to 7 days for those in the ECU setting. Next slide. This is a big one, so I'm just going to try and hit the highlights here. There has been a lot of changes with the CDC guidance and with CDPHE guidance. I think the overarching theme for our K-12 guidance is prioritizing in-person learning. And so all of these changes were made with a nod towards that, because that means both minimizing quarantine, but also minimizing exposure to COVID-19 positive cases. Just a little bit of history here. We started looking at updating our guidance in December of 2021. Of course, the CDC, without much foreshadowing, released K-12 guidance last week, and CDPHE just updated its guidance. Our guidance that we had been developing locally based on our local data was adopted by many of our partners, and that is what we have implemented. So I'll just highlight for you real briefly where we do diverge from the CDC. We have determined that it would be most effective, especially in light of Omicron, to include boosters in the definition of fully vaccinated, and that becomes relevant for quarantines, particularly in high-risk settings like sports. We're also permitting a 90-day exemption for quarantine after exposure, as long as you were, it's complicated, and I'll let one of the EPIs explain the details of this. But basically, looking at our data and seeing that there's a 90-day natural immunity period, we're exempting that for quarantine, so we can keep those kids in person as much as possible. We do have the quarantine for high and medium risk contacts. These are mostly sports. This is an area that we saw a lot of outbreaks in over the past year and a half. We have not seen a lot of classroom transmission, and so far that continues to hold true, but of course the semester only started less than a week ago, so we're still watching that very closely. Schools can opt into surveillance testing that is provided by CDPHE. We do have some public schools and some private schools who have opted into that. We are going to continue with not routine quarantines, doing routine quarantines for classroom exposures. So that means if there's a positive case in the class, that does not necessarily mean that the whole class gets quarantined. Like ECE, if an unvaccinated student has a positive COVID-19 case at home, they must stay home. And like ECE and like the guidance for general population, it's now a 5-day quarantine with the 5 days of required masking. So that becomes, because masking is required for everyone, that becomes relevant because the students with medical exemptions must do a 10-day quarantine. Testing is encouraged, though not required under our guidance. And the same change we've made for isolation. It's now a 5-day isolation period with 5 additional required days of masking. Another significant change, because the kindergarten population is 5 and older, if you look at the age cutoffs, I believe everyone is over the age of 5 now. The kindergarten is now following the rest of K through 12 guidance instead of sticking with ECE. We have had to prioritize our resources, and because of the pretty horrific graph that Lexi showed earlier, that we're now at 1,200 cases per 100,000, we've had to stop case investigation and contact tracing except for outbreaks. We have sent notifications out to parents. We partnered with the schools and asked them to send a letter on behalf of BCPH, effectively informing parents that this might happen and that we really need their help. And that means keeping your kid home if they're sick or have any signs of symptoms and getting tested. And we have to rely on that because parents should not rely on being notified of a positive case. Our resources are now focused on data entry so we can keep an eye on what the data is actually doing. Next slide, please.
So just to note, that's the end of our K-12 update, and we'll do policy updates next in case there are questions on K through 12.
Thanks, Lexi.
I just want to jump in and say thanks to the staff, the whole team for working on this and doing that whole shifting the dance, as I know guidance has changed at all levels. So I really appreciate that. And again, that prioritization of in-person learning and trying to balance the safety. So thank you for all of the work that's been done in the last month in particular on this. So thanks.
And hi, this is Lindy. I just wanted to acknowledge the public comment that came earlier in the meeting and the concern about not having children test negative before coming back to the classroom. I would just say that I understand the balance we're trying to strike here, and it's very difficult, I think, to make these decisions, but I am concerned that we are not testing kids as negative before they return. So I just want to make sure I made that clear in terms of my own personal opinion on this, I think. But from a policy perspective, I understand the balance we're trying to strike here. I don't necessarily think that in a vacuum, that's the best decision.
If Soda's on, she might be able to best speak to that.
Hi, so this is Sandra Snoda. Everybody refers to me as Soda. So one of the things that we tried to balance is we know that we have a mask order for our schools, and that is something that we know can help with the transmission reduction in our schools. So even though we realize that in the best of all possible worlds, we would love to have a test to return. Right now, we are seeing incredible difficulties with getting either at-home tests or being able to access the community testing sites. The wait times have been long. The turnaround times for some of the PCR tests have also been long. And at some level, we are also worried about access and equity issues regarding our testing capabilities for the entire state, not just our county. So those are the things that also had to factor in. And we wanted to really emphasize trying to keep kids in school. We know that this is a huge burden on families to be having them in and out of school. And it is something that we are really, really aware of, mental health issues and being able to learn. So some of these things just, we had to make some compromises, and we had to realize what some of our limitations are in the county around testing, and what was the driving thing that we needed to prioritize.
I'll make two additional comments.
Oh, sorry.
One,
And I was just going to acknowledge that I think it's important that we acknowledge when we're making compromises, because these are frankly terrible decisions we're having to make in many cases, right? And you know, sometimes not completely substantiated by data. And I think it's always important to, in these meetings and the way we're speaking to the public, be transparent about that. So I just wanted to make sure that was, and thank you for saying that so eloquently back to me and really explaining the decision, because these are not easy decisions. And I just want to make sure that's really clear.
I'll also add that there were some significant operational issues. We have a real, I think everybody knows there's a paucity of tests right now, and the infrastructure to perform the tests was not judged to be in place for the school staff to be able to pull that off. I know that CDPHE had approached the Colorado Department of Education to talk about the possibility of testing for return to school. And the Department of Education felt that it was not feasible at this time to be able to really have the staffing to do that. And CDPHE also recognized that the number of tests would be difficult to achieve that.
Thank you. Appreciate
Michelle,
it.
did you want to add some more?
Yeah, I also wanted to comment. I mean, we wrestled with this with healthcare workers last year, right? You know, to test to return to work. And, you know, the challenge with the PCR testing is it picks up viral fragments. And I have certainly cared for people, you know, or been consulted on people who were, you know, positive 60 days out, but totally fine and resolved their clinical illness. So that it presents another layer of complexity, because you have to understand, like, which test are we going to, if we're going to test to return, which test are we going to use? Because the other challenge is now there's some emerging data about reduced sensitivity with the antigen tests to Omicron. So we need to understand what that really means when someone's on day 4 or 5 of their illness and their symptoms have resolved. You know, are we really going to be are we really increasing the protection of kids at school, or are we adding another layer of complexity with very little benefit? And that question, I think, is unanswered at this point based on the data. And then there's the pragmatic issues that we've already discussed.
Thank you.
Trina?
Thank you. I'm going to give you some policy updates, starting with the local at Boulder County and kind of moving out to the state and the federal levels and how those will affect Boulder County. So the first policy update, a reminder that our universal masking order is still in effect. It's been since September. I feel like we say this every time, but it's always a helpful reminder. We have adjusted our isolation and quarantine guidelines to that 5-day period based on the CDC's changes, and that is incorporated into our order, which says that you must isolate or quarantine if you have an exposure or you're a close contact. We've made a big push in the last 2 weeks or so emphasizing that folks should prioritize an N95, KF94, or KN95 or similar well-fitted mask over even a surgical mask, and definitely over a cloth mask. Just today, we updated our website to give the general public a description of what that means. There's been a lot of questions. Do I need an on-brand N95 or KF94? And the answer is the best mask is the mask that fits you well, meaning that it fits snugly with no gaps and that it has multiple layers of a non-woven material. And of course, the KF94 and KN95 fit that criteria, but the emphasis is really on what fits you personally best. Our vaccine verified facilities program, this is those facilities that require proof of vaccination to enter, and if they hit a 95% proof of vaccination for every single person within the facility, then they have the option of allowing folks to remove masks. We've been in communication with our approximately 300 facilities that have applied and been approved, and we've told them, hey, we're in a surge right now. We recommend that you put on masking, that we're not going to require it. And many of our facilities have. We've also alerted them that it's very possible that boosters may become a requirement should the definition of fully vaccinated be updated. Next slide. On the state level, there really haven't been a lot of orders put in place. CDPHE has extended its proof of vaccination for indoor unseated events order until January 31st. I suspect if this surge continues, that order will continue even further. I think the thing of biggest importance is that their proof of vaccination requirement aligns with our own. So it's the same, use your My Colorado app or show your CDC vaccination card. Next slide. For our neighbors, I said state level, but what I really mean is what's going on in the other local jurisdictions around the state. We now have mask orders in many jurisdictions, including the ones listed here. Almost all of them align with us and are in effect until certain metrics are met, with the exceptions of Broomfield, which now does have a universal indoor mask order for indoor public spaces. For a long time, it was just their government buildings, but now that has been extended to all public spaces, including businesses. And Denver has extended to February 3rd as a hard deadline. It seems that they are just on a 30-day renewal kind of track. There is a pretty interesting lawsuit out of Douglas County. Actually, it was just one plaintiff brought a lawsuit saying that the new Douglas County Health Department's anti-mask order is outside of public health authority, and that Douglas County did not legally separate from Tri-County. This is interesting legally. It's in the very early stages, but basically it's saying, hey, public health department, you can't pass an order that is not going to protect the public health. So it'll be interesting to follow that and see where that goes. Next slide, please. On the national level, you'll recall that there are kind of two major regulatory changes that have gone into place. That's the OSHA rule requiring vaccine for employers of 100 or more people, as well as the CMS healthcare worker vaccine requirement for all healthcare facilities that accept Medicare or Medicaid funding. The Supreme Court heard oral argument on these. And I think what's important to note about this is the legalities of this really boil down to a lot of statutory and regulatory authority. It's nothing particularly sexy about vaccines themselves. It's about statutory and regulatory authority of OSHA and of CMS. So we'll see where the Supreme Court comes out on those. Many employers have gone ahead, and as far as I can tell, the legal advice in general has been you should go ahead and plan to implement these requirements. But of course, until they're actual requirements, we'll see what happens. The Transportation Security Administration has continued its mask order through March 18th. I find this one very interesting to track because the dates always seem kind of arbitrary to me. I like to see how far out TSA is anticipating things, as well as the CDC. And of course, the 12 to 15-year-olds are now eligible for a booster. And I think it's back to Lexi, unless anyone has any questions.
So we just wanted to conclude this evening with kind of a step back on where we are with our broader strategies. And I think most of you will remember this slide about layered mitigation strategies and really trying to emphasize what's easy and essential and only move to more burdensome strategies when we have to. What I will note here is that the strategies in green are strategies that we are currently really stressing and emphasizing. Those that are in bold are ones that we have refined lately. So in terms of masking, really pushing high quality masks, now adding on encouragement to voluntarily limit gatherings and to work from home or remotely. But we also note that some of those strategies in red are becoming more challenging in terms of their effectiveness. Case investigation, contact tracing, asymptomatic testing, both because of the shortage of tests, because the at-home tests seem to be a little bit less sensitive. And as we move through this surge, there may be further refinements that we will think about in relation to these mitigation strategies. Finally, if we kind of go back to what that long-term strategy was, it's really about how do we support Boulder County as a community to create habits and self-adaptation to really respond to what's happening in the community in relation to this pandemic. And we really did feel like we found agreement on the shared goals, which was important. We were able to design some public health orders that support ongoing course correction using kind of triggers as opposed to standing orders up and down, but really kind of create an expectation that when such and such is the case, that the community will respond X way. And then in terms of that, that really key piece of ability for the community to self-correct, we worked to embed power for self-regulation in the community as much as possible. That included things like providing supports, creating policy supports, ensuring public access to ongoing information and data. I think the VVP was a mechanism for the community to really be able to meet its own needs. We've seen lately many businesses and organizations adopt staff vaccination policies. We continue to work with and advise schools, businesses, and other community partners to manage their needs. We are providing PPE to particular groups that have a special vulnerability, including folks like our fire-affected families. And we also continue to work with businesses and organizations for whom various mitigation strategies present challenges. So, we're not through the pandemic, clearly, but we are hopeful that we have really supported the community to take power in their own hands, to see what's happening in the community, and to really create opportunities for themselves and their families to be healthy as we move through the next few weeks.
That it, Lexi?
That's it.
Any other questions from board members? I'll just echo that sentiment again, but to all the staff and management team at Boulder County Public Health, you guys have some really hard challenges, really difficult decisions to make. Add the fire response on top of it. I'm just so grateful for all of you. And, it's sad. 1,200 cases per 100,000. How much higher can it go? And it's just so depressing to look at these numbers and then to, be questioned.
Oh, Greg, you moved to mute.
Oh, sorry, I accidentally muted. It's okay. I just wanted to express my sincere appreciation to everybody involved in both of those efforts. So thanks.
Greg, thank you for those comments. I've been struggling to figure out how to answer or ask this question, and I know it's a question that probably doesn't have a great answer at this stage, but given the fluidity of the situation and the numbers that we're seeing, which are obviously not going in the right direction, and some of this is my lack of experience in the beginning, we have definitely changed and shifted our policy making, right? And I think that is the right thing to do. What are the thresholds that we are considering whereby we would have to move to more severe mitigation strategies? And I'm not suggesting that anyone would like to do that, nor do I personally want to ask that question, but I feel like sitting here looking at this data, looking at the thresholds by which we are considering the community impact, I just felt that it was important that I ask that question.
I think, I'll say very little about it, Lindy, because I think it is, as you say, it's really dynamic. These cases have come very quickly, over a holiday, no less, and in the middle of, another emergency response that was really traumatic for our community. I think what we're watching our health system. We're watching our hospitalizations. That has become a critical focal point. We're talking with our friends in neighboring counties. Camille talks to them all the time. She keeps abreast on what they're thinking, we're trying to talk with our community partners too about what they see as the critical thresholds. And those make for a pretty complex dynamic. And I think one of the challenges of this particular policy question that Camille and I have talked about a lot is, if this variant really does move through our community this quickly, can we create a policy response that's going to be helpful in time? Or are we going to be Johnny-come-lately to the policy game because it'll be gone by the time we get everything in order? Because when we work on these policies, it's, we don't just push them out the next day. There's a process of vetting, testing, communication that is behind all of them. So I think it's a great question. I think it's, of course, something that we ask ourselves every day. I know Camille and I talk about it, and I think I feel like every day we could have a little bit more information for you. If you wanted to have a Board of Health meeting every day, we could do that. But I don't think anybody wants to do that. I think the best strategy forward is probably, excuse me, is probably to keep an eye on things. Yeah. And for Camille to, raise a flag when there's something important to discuss.
Thank you, Lexi. Really appreciate it.
Okay, any other questions? If not, we will go to the final next item on the agenda, director's report. I know that the director's report was obviously later this month because of the various response activities by the staff. Totally understand. And again, but is there anything anybody needed to discuss from the director's report? Camille.
That's what I was going to say. President Thomas, we've had so much time together this evening. I won't expound, other than I just want to emphasize how hard it was to put in words how much I had gratitude and continue to have gratitude for all of the work that staff did on the response while also working on the pandemic. And might I add that as someone still new to Boulder County government, how impressed I was with the response in general with Boulder OEM and all of the other department heads. I can't go on enough about how everyone had all hands on deck for this fire response, while also listening to us while we said as public health professionals, hey, while you're out there, please put on a KN95 and please get tested and please be careful in this pandemic. So this was truly something that I couldn't find the right words to express, but wanted to just share that briefly. But with that said, does the board have any questions for us about this lighter director's report this month? Thank you so much. Thank you. Well, President Thomas, it looks like there are no questions, but as always, the board knows how to reach out to me. And as Dr. Nolan said, when it's time, I would reach out if it were time to change policy. One of the strengths that we have from Dr. Nolan's presentation and everyone that participated is the consistency with which this board and this community has supported the policies that are currently in place. And when we're talking about how high could it go, I don't even want to speculate that, but I will say that I'm appreciative of the consistency with which we have enacted and kept our policies in place to protect and promote health in this community. So thank you so much for your time this evening, Board of Health.
Thanks, everyone. I don't know if, Greg, are you still there? I was wondering if we should. I don't think there were any other agenda items.
I was just about to say,
Okay.
Member McMillan, in your role as Vice President, if President Thomas had to step away, we had no other action items, no other agenda items, so I would think it's okay to move to adjourn.
Great, and I do want to say, I know that we had trouble connecting with one member of the public who was intending to speak, and just encouraging that member of the public to send us an email. And again, we do read all of these emails that come to us either remotely or if you do end up speaking in our meeting. So please do follow up with us, and we appreciate public comments. So thank you. And I guess I don't think we need a motion to adjourn. I think we can just adjourn the meeting. So thanks, everyone. Thanks to the staff.
Thank you, everyone. Really appreciate it.
Thank you all. Good night.
Good night.